This is a diagram from Byrne and Levy. It's not in the chapter that's on the drive, but it's a really nice overview of the whole circulatory system. And the heart is at the center of this system here, and it's got 4 chambers. The left ventricle creates the high pressure to push blood out through the aorta to the entire body, both up and down, head and towards your legs. And that blood goes out into a capillary network that perfuses the muscles and organs, comes back through large veins to the heart, goes into the right side, goes to the lungs to get the blood gets reoxygenated, comes into the left atrium, and then into the left ventricle and out again. And so this shows sort of the scale at which things are occurring. Most of the blood is down here in these small vessels in the tissues being perfused, and when you look at the pressure down at that level, it's fairly constant. There's just a constant pressure gradient along the vessels, the small vessels, which keeps a steady flow going. Whereas in a large vessel like the aorta, the pressure will oscillate considerably. It'll go between, say, 120 millimeters of mercury down to 80 or 90, something like that, over the course of the heart cycle. And that's what you measure when you measure blood pressure in your arm. You should know this diagram. We'll have a couple of diagrams about the basic components of the heart, and you should know all of the parts of this diagram and the basic flow of the blood through the system. So we'll start here. This is the left atrium. Blood comes in from the lungs to the left atrium through this valve called the mitral valve to fill the left ventricle. On each heartbeat, the left ventricle pumps blood through the aortic valve here, out through the aorta, and perfuses the rest of the body. Blood comes into the heart from above the heart through the superior vena cava, and from below the heart, inferior vena cava, and it goes into the right atrium. And that's a conduit to the right ventricle, and there's a tricuspid valve here, similar to the mitral valve, that the blood flows through into the right ventricle. When it contracts at the same time as the left ventricle, both of these valves close, the tricuspid and the mitral. They both shut as the heart contracts, and blood goes up through the pulmonary valve into the pulmonary trunk and out to the lungs. And what you hear when you hear the lub-dub, lub-dub, lub-dub in a stethoscope are those valves closing, right? So it's either the mitral valve and the tricuspid valve closing together, or the pulmonary valve and the aortic valve closing together. Those are the primary sounds that you hear. With a stethoscope, you can also hear blood rushing through these valves the wrong direction. So if you have a small abnormality, say, in your mitral valve and blood is rushing through it, you can sometimes hear it as a hissing sound or a burr or something like that. And so you can do a lot of diagnosis just from sound. But MR and CT and echo and everything else give great pictures of all of the normal function of all of these parts. So you should know this diagram. Okay, just simply you should just have it memorized so that you understand where the blood's going and what the parts of the heart are. Here's some supporting diagrams. This is a classic medical textbook by a guy named Netter, who was a really famous medical artist, showing the position of the heart in the chest with the lungs, and it sits inside this sac called a pericardial sac, and it isolates the heart from the rest of the chest. And the pericardial sac also is very, very slippery, so when the heart contracts, the surface of the heart, the endocardial or the epicardial surface of the heart outside can slip on this sac. And when you have cardiovascular surgery, they need to cut this sac and open it up to get to the heart, and then most of the time they just leave it open, right? And so the heart becomes sort of in a different mechanical condition under those at that point. One malady you can have is if you punch a little hole in the heart somewhere, say you're doing an intervention and you poke a little hole, blood can leak into this pericardial sac, and you'll have a pericardial effusion of either blood and sometimes other fluid like water can get into the pericardium, and that puts pressure on the heart. The major muscles that we'll be concerned with in the heart are basically the myocardium here of the left ventricle and the right ventricle. They share a wall called the septum. And the labels you need to know are the epicardium is the outside of that muscle wall, and the endocardium is the inside. And those are the things that you see on echo very clearly, are these boundaries. And the valve plane, or if you sort of put a least squares plane fit through all of the valves, that you would call that the base of the heart. And then as you move down towards the pointy part down here, the end of the football, it's like one half of the football, that's called the apex. So there's the base and the apex. And so when you have an apical view, that means you're looking usually from the apex up, right? And if you're looking at the base of the heart, you're usually looking up here at the valves and the myocardium up towards the valves. There's a very nice YouTube movie that shows essentially the normal dynamics of the motion of the heart, and it'll pop up different annotations as it points out different parts of the heart. So I would recommend just going, and we won't watch it right now, but it's actually quite useful. It just has music over top of it, so you don't have to listen to it. You can just watch it and look at the labels. Okay. This is the normal motion of the left ventricle as measured by dynamic CT. And so in this imaging, what we're doing is we've injected contrast into the entire bloodstream of the patient. And we've injected it through a vein in their arm. And about 10 seconds after that injection, the contrast is pretty well uniformly distributed through the left parts. So it's in the left ventricle, left atrium, the aorta. And the contrast agent attenuates X-rays much more readily than the native tissue. And so it looks brighter on the CT scan. So you can easily segment that signal out and make a three-dimensional volume just from the bright stuff. So we're looking at the surface of that three-dimensional volume from the bright stuff. And dynamically, we're taking an image every 150 milliseconds, and so we play those back, and you get a movie. This is a normal left ventricle, normal left atrium. So you can see there's kind of uniform contraction of the entire left ventricular chamber. It contracts down. It usually ejects about 50% of its volume, up to 75% of its volume, something like that. And that's sort of a normal ejection fraction. If this left ventricle was only ejecting, say, 15% of its volume, then you would say that ventricle is failing. That's heart failure. It's just not able to eject the volume. Also, this atrium, this is the left atrium, and those four vessels going into the left atrium at the top here are coming from the lungs, and those are the pulmonary veins, and they're carrying blood to the left atrium from the lungs. And the left atrium itself has a little kick or contraction right at the start of the heartbeat. So at the start of the EKG, it's a P wave, and that's the depolarization of the left atrium. And that helps, it's like a turbocharger. It fills the left ventricle with about an extra 10%, 15% of blood volume from the atrium itself. It just kicks it in there. The left ventricle stretches a bit and then contracts. And we can see particularly this little chicken wing thing here, which is the left atrial appendage, shows the timing of that left atrial contraction quite well. You can see it just sort of doing a quick ejection of its volume. That left atrial appendage can be problematic sometimes if the left ventricle or the left atrium is not contracting well. Blood will pool in that little appendage, and you can get thrombus, and then the thrombus will leak out and you get a stroke. So 80% of strokes in people with left atrial fibrillation are from that little fella, that chicken wing. So one therapy for that is you can actually either just cut it off, you can fasten it down at this side, or you can put a plug into it and shut it off. Or you can take drugs that limit the coagulation of blood, which carries other risks, though. So here is essentially normal cardiac function as viewed from the traditional views that a cardiologist would look at either with echo or CT or MR. So these are the 6 panels here show the traditional views that you would look at with cardiac imaging. These are called short axis views, and remember we looked at that diagram on Tuesday when we looked at echo. When the short axis is cutting the heart such that it looks like a donut, the left ventricle is here, ejecting the blood, the right ventricle is over here. This is the patient's liver, this is their chest wall or sternum is right here. Normally the heart or the image itself, the view is rotated such that you're not looking at the patient flat, you rotate the patient so the heart takes on this appearance where the lateral wall is at 3 o'clock and at 9 o'clock you're in the middle of the septum. All right, that's the traditional, if you see a heart, it should be in that orientation. The other thing is you should be looking from the apex of the heart towards the base. You can imagine you can also flip that around and look the other way. And oftentimes engineering students, when they're using MATLAB, they work on hearts that are mirror inversions of the actual thing for a year before somebody points out, hey, your heart's inverted. And that's just a simple Z to minus Z that happens when you go from, say, C to MATLAB. So this is the apex of the heart here, down towards the pointy bit, right? The middle part of the heart, and then up towards the valve is the base. And normally you get 3 views. Obviously from CT and MR we can get 20 of these slices. You know, you can cut it up much more finely than this, but in tradition, you know, with echo is that these are the 3 views they're going to look at. If we cut these views along planes like this, we'll see long axis views. And the first one that I'll point out is this one in the middle. This is called a 4-chamber view, and that corresponds to a cut right through here. All right, so I've got the septum, the lateral wall, the right ventricle. So here's the septum, lateral wall, right ventricle over here, and then both the right atrium and the left atrium are contained in this view as well. So you get to see the entire picture of how the volumes are working. And this heart looks normal in the sense that the myocardium is getting thicker as the heart ejects blood. Okay, so at each point, you can look at that signal for the muscle there, and it basically gets thicker with time over the ejection phase. This view is called a parasternal view. It's more like this cut through the heart. And so you see the left ventricle, you'll get the down here, it's more towards the posterior wall here, sitting on top of the liver. You get the anterior septum, a little bit of the right ventricular outflow tract, but you also get a really nice picture of the aorta and the aortic valve, as well as the mitral valve here. And so this is often the first view that's looked at with echo, for example. They just put the transducer on there and take a look at that view. So you get to see that how both valves are working and how these 2 walls are working. And then a 2-chamber view, this is the last one here, is if we cut the ventricle right down this axis here. All right, so basically we have the anterior wall of the left ventricle and the posterior wall here sitting on top of the liver. All right, so this is the liver down here. And now in the long axis, we've sampled, you know, essentially 6 different segments of the myocardium and how it's contracting. And so that's sort of a complete view of the heart. People get really good at reading these. So if you pop these views up in front of a cardiologist, they will tell you if that heart's normal in about 1 second. They just look at it and go, okay, that heart's normal, just like that, because they get so good at reading them. They've seen so many. So it's well worth your while when you're creating images to show to a physician to give them images in views that they are well trained at looking at. If you give them a novel view, they don't know if it's normal, so they look at it for some time, figure out what the hell the view is, and then figure out whether or not the heart is functioning normally. So a parameter used to evaluate how well the heart is performing is called ejection fraction. It's a very simple parameter. You take the volume of blood at end diastole when the heart is the most full of blood, the left ventricle is the most full. You take the volume of blood at end systole when the heart is contracted and so it's the emptiest, and just take that difference and divide it by the starting volume, and that's the fraction of blood that was ejected. Normal EF in echo is about 50 to 60%. If you do EF with CT, you get a different number actually, because you count more of the pixels, and it's usually around 70%. The CT is normal ejection fraction. Another parameter to determine whether or not a heart is normally contracting is the longitudinal strain or longitudinal shortening. And the base of the heart, this is where the valves are. So the mitral valve would be right above the opening to the left ventricle here. This is the apex. What happens during contraction is the base or the valve plane of the heart moves down towards the apex. The apex remains pretty well in place, just in absolute lab coordinates. It just stays there, and the valve plane moves down towards it. That makes sense because you're ejecting blood, and the atria are filling with blood when you're doing that. So you're just exchanging volume between the atria and the ventricles, and so the valve plane moves down. So the amount by which that valve plane moves down, if we take the position in lab coordinates at time t0 at end diastole, and then look at that position at end systole, and take the ratio of those lengths of the heart, of the ventricle, that is called longitudinal strain. So it's just L prime minus L divided by L, right? Much like ejection fraction, but now it's a length, right? And it's a strain, essentially. This parameter is very simple to measure. It's easy to measure with echo, for example, because you can put the transducer at the apex of the heart and look up towards the base, and then you can measure that lengthening fairly accurately. And so this is often done with echocardiography, and it's shown that this strain parameter is indicative of whether or not the heart is performing well. It's also indicative of whether or not the heart will recover if you treat it with something. So if a person's in heart failure and their longitudinal strain has been reduced to close to zero, that's bad news, right? That heart's really, really struggling. Another way of doing this some people do is they measure the total length of the chamber, from base to apex, then back up. And if that's easier to do, you can do it that way. So radial wall thickening is another traditional parameter for measuring cardiac function. So if I have a heart in a short axis view now, so it looks like a donut, the left ventricle is here, this is the patient's liver down here, their chest wall, right ventricle, left ventricle. So now if I measure the dimension of that wall, and let's say it's 1 centimeter at end diastole, so when the heart's full and I look at the thickness of the muscle and it's 1 centimeter, then at end systole, when I've ejected the most blood I can, and I measure the dimension of that wall again, it's going to be thicker. Right? It's going to be bigger because basically you shrink down the chamber, and to do that, the muscle contracted and it made itself thicker. Right? It does this once a second for your entire life. Right? So it's an incredible muscle that way, in that if you tried to do that with your bicep, just do a curl, a light curl, like with 5-pound weight or something, for your entire life. Right? Eventually that muscle doesn't respond to that. Myocardium, on the other hand, it just keeps on going. It's pretty incredible how the metabolism and everything is set up to do this. So the way you can measure function this way is just the ratio of those thicknesses. The thickness at end systole versus the thickness at end diastole. And if that thickness has increased by 50%, using this formula, that wall thickness at end systole minus the wall thickness at end diastole divided by the original wall thickness at end diastole, that's 0.5, it's increased by 50%. Right? So that's radial strain. That actually is a harder thing to measure than longitudinal. And the reason it's hard to measure is, even though it looks pretty obvious here where the endocardium and epicardium is, oftentimes it isn't that obvious. It can oscillate a little bit depending on whether or not the person deciding where that is contours it aggressively or not. So, and also there are structures that get in the way. For instance, these papillary muscles here get in the way of determining what that wall thickness is. So you usually have to make a smooth curve through the endocardium, and that introduces variability, which introduces non-reproducibility in this parameter. And so it's specifically when this value is low, like down around 0.1, 0.15, it can be pretty noisy. Right? So it's a tough thing to do. Looks easy here though, right? Because the images are such high quality in these pictures. But when they get lower, it comes harder. The other parameter is circumferential strain. And that one, if you measure the distance of the circumference of the chamber, like the hoop distance, and then you measure that at end diastole when it's full, go to end systole when it's empty, and you measure that circumference again, right? Then you can get the circumferential shortening. And again, it's a strain. You know, the length gets shorter, obviously, as the chamber contracts, that length gets shorter. So it's a negative number. And, a normal shortening is about 35%, something like that, circumferential shortening. You can do this locally. You don't have to measure the whole circumference and the whole circumference. You could measure it over a certain region, say the anterior part, and get local circumferential shortening, as you can with radial wall thickening. And then an interesting parameter that is becoming talked about more in literature is the twist or torsion of the left ventricle. And it turns out when the left ventricle contracts, and I'll show you some tagging data where you can see this. If you look at it as short axis, and we're looking at the apex, what happens is it rotates as it's contracting. And it rotates in a clockwise direction, and then up at the base, it rotates in the opposite direction. And so the heart, in addition to shortening, is actually doing this torsion motion. And that torsion motion is indicative of normal function. If you lose that torsion motion, something's up, something's going wrong. It turns out if you get, for example, a heart transplant, normally you're on drugs to basically suppress your immune system so you don't reject the transplant, but rejection can still occur. And so what they do is they do biopsies of the tissue to see if the tissue is being rejected. But it turns out if you measure the twist of the transplanted heart, the twist goes away before you even see evidence of rejection from doing a biopsy of the muscle. And so it's a really sensitive marker for whether or not the whole tissue is behaving normally. So you measure the angle of rotation at the base, the angle of rotation at the apex, and so here you have basal rotation, apical rotation in blue, and then this is the final torsion as a function of time through the heart cycle. So at end systole, the torsion is the maximum. And so this is usually about 20 degrees, right? Somewhere between 15 and 20 degrees in a normal person. Pressure waveforms are another thing that is essential to figure out whether or not the heart is working well. And so this is the pressure waveform, say in the aorta, right, just outside the left ventricle. And so you can have a mean diastolic pressure. So when the heart isn't contracting, say at 80 millimeters of mercury, and that's because you've pressurized the aorta, and the pressure drops back down to a sort of baseline level that is positive because it still has to push blood. You want that to stay positive. You don't want to go down to zero, right? Because you don't want all the blood to stop flowing. It flows continuously. And then when the heart contracts, it creates a higher pressure, up to 120 if you're normal, during systolic contraction. Okay? And this is measured usually in a brachial artery, which is fairly close to the source of the pressure. So these parameters are measured in virtually everyone when you go for a physical to determine whether or not your heart is functioning adequately. You don't want it to be too high because that is a risk factor for developing cardiovascular disease and stroke and everything. And you don't want it to be too low because then when you can stand up, you just faint, right? So you want it somewhere in the middle. And you find that an anesthesiologist, when they have a patient on the table for surgery or any kind of intervention and the patient is anesthetized, they're constantly looking at this signal just to make sure everything's good. If this signal starts to drop, the pressure starts to drop, you have to ask yourself, what's going on here? The heart is bailing on us. It's not producing the pressure. So usually you can give some drugs to bring the pressure up. And this is a classic diagram showing the pressure in different components of the heart. It's called a Wigger's diagram. And this one is pulled from Byrne and Levy. But you can just memorize this page here. You don't have to go back to the primary chapter. But you should know this diagram. It's a very important diagram. So this is pressure in the aorta that we just looked at. So you have a mean pressure, sort of around 80. When the aortic valve opens and the left ventricle creates pressure, it goes up to about 120. The aortic valve closes as the ventricle relaxes, and then that aortic pressure drops off slowly. You can see these two notches in that curve, and that's when the valves are opening and closing. So here it's opening, there it's closing. Here, this solid curve is the pressure inside the left ventricle, okay? And because it's behind the aortic valve, it can drop quite low as it relaxes. So as the pressure in the ventricle increases, the mitral valve, remember the valve to the left atrium, you don't want the blood going back to the left atrium. You want it to go out the aorta. So that mitral valve closes, right? And you can hear that. That's the first heart sound, dunk. And then the pressure increases, the aortic valve opens, a few milliseconds later, pressure continues to increase, and then the heart relaxes, the muscle relaxes after end systole, and the pressure precipitously drops because the muscle has stopped creating pressure, and it actually relaxes and can actively spring back and cause a pulling down of the pressure, and that slams shut the aortic valve, and you hope the aortic valve is working well, and so that keeps the pressure in the aorta, and then the pressure in the left ventricle goes down, and blood flows into the left ventricle from the atrium. Okay? And so you get filling during this phase here. If we look at some of the other curves here, this is the correlated left ventricular volume, right, which is one of the easiest things to understand. It's basically the ventricle is full of blood here, and then it ejects the blood in this temporal pattern. And then when the aortic valve shuts and the ventricle is relaxed, it refills with blood. And this little bump here is atrial kick. That's a bump up, in the volume as the atrium contracts. All of this, you can measure the timing with respect to an electrical signal on the surface of the body, which is your EKG. And these are voltages between, 2 points on your body, say your right arm and your left leg or something. If you could, make a movie of surface potential, right? You would see colors evolving every heartbeat because you have potentials across your body. So all you do is just put ECG leads on there and you measure that voltage and you get these signals. And this is left ventricular depolarization. That means when the electrical signal goes to the left ventricle and causes it to contract, causes the muscle to contract. And this is repolarization, or the T wave. And that's when the ventricle gets set back to beat again. And then aortic blood flow is shown here in timing, and then these are the heart sounds that you can measure with a stethoscope. Okay? I think that covers that one. Any questions on that diagram? This is a really important diagram. I encourage you to look it over and be able to draw it on your own. So what is the most serious acute problem you can have with your heart is coronary disease or acute coronary syndrome. And this is when one of your coronary vessels, the major vessels on the surface of your heart, gets blocked. And unfortunately, as humans, we develop these lesions on the inside of our coronary vessels that over time make the wall of the vessel thicker and thicker and thicker and close down the lumen of the vessel such that it gets thinner and thinner and thinner until finally, in some people, that lumen goes down to about 5% of its original area. And then you find that you're in a situation where if you run for the bus or you go upstairs or something and your heart rate goes up and the demand for blood in the myocardium goes up, the vessel is not capable of providing that blood flow. The maximum flow you can get out of it is well below what is needed, and then you get pain because you get ischemia in the tissue. If you're lucky. If you're lucky, you get that and you get pain and you get an EKG abnormality and you feel sick. And then you can go to the hospital and say, you know what, I think I'm having this acute coronary syndrome, and they'll take an angiogram and they'll open that vessel. And then all is well with the world, right? You didn't have a heart attack, the tissue survived, everything. If you're unlucky and you're a really tough person, right? And it's interesting because it turns out that males have a lower pain threshold, it seems, than females. And so females will just push right on through heart attacks more often than males. But males, they get this clutching feeling and this shooting pain and stuff like that. And so they show up at the hospital. That's the lucky ones. If you're unlucky, you basically don't have any symptoms, and then the vessel closes and the blood flow goes to zero. And then at that point, you are having a massive heart attack and you just fall down and you die. And that happens to about 30% of the people that have heart attacks. The first symptom that they have heart disease is that they're dead, right? And so it's kind of a catastrophic event. And that's why knowing, your condition that you're in and whether or not you are a person that grows lesions, in my opinion, is a reasonable thing to do. And we can talk about how that's done with, calcium imaging, etc. So these are the major vessels. They come off the root of the aorta. There's the right coronary artery, and it feeds the right ventricle, and it oftentimes goes all the way around the posterior side of the heart and then goes down and feeds the posterior wall of the heart and the apex. Another major vessel is the left main. Two vessels come off the aorta. The right coronary artery and the left main coronary artery, and the left main's back here. It comes out and goes straight down the front surface of the heart in the groove between the right ventricle and the left ventricle, and it's feeding the septum and it's feeding the left ventricle, and it too feeds the apex of the heart. And then a branch up here called the circumflex is kind of like the complement to the right coronary artery. It goes around the back of the heart, drops vessels down the posterior side of the left ventricle, and then can connect up here and go down the back. Some people are left dominant and their circumflex perfuses the back of the heart. Some people are right dominant and their right coronary artery perfuses the back of the heart. When you're developing as a fetus, both of those systems are developed. One of them fades away, which is too bad, right? You'd think you should have both of them active because then you have a redundant system. But it turns out humans don't really have great redundancy in their coronary vessels. Dogs do, for example. They have sort of cross-feeding of areas so that if one drops out, another one will take over. If you're a left dominant person and the back of your heart and the front of your heart on the left side are fed by this vessel, if you have a lesion in your left main that feeds both of those vessels, that's a serious problem, right? You've dropped, 2/3 of the blood flow to your heart and you're in big trouble. So if you have a big lesion, you can't see it, it's behind the pulmonary artery here. If you have a big lesion in your left main, usually they do a bypass surgery. They'll just put a new vessel from here, bump, and plug it in down here, right? Or they'll take a vessel from your mammary artery and plug it in down to here. So you should get to know the basics of this diagram and where these vessels are. It's worth knowing. Okay. You can image it really well with CT now. This is a CT scan, 3D, done in about 150 milliseconds. All right. You inject contrast agent, as we were saying, and then in one heartbeat, the thing rotates around and goes whoop, and takes 150 milliseconds worth of data and produces this. So you see all of these fantastically rendered vessels here. This is a normal right coronary, a normal left main, normal left anterior descending, normal circ. Right? This person's right dominant. You can see the right coronary artery coming down the posterior side. Radiologists and cardiologists who read these for a living to determine whether or not somebody has cardiovascular disease, they never read this, the 3D image, for determining whether or not a lesion is significant or not. They will display this 3D image to determine whether or not the study that they have just obtained is good. Right? So they'll look at it and say, oh, this is a great quality study. They then go back to the original imaging planes and just page up and down through them and look at the vessels. It's an interesting process to watch, and different styles for different people. Yeah?
When it comes to being left and right dominant for blood vessels, is one more predominant than the other?
I think it's about 50-50 whether or not people are left dominant and right dominant. And it obviously makes a difference, for your care, depending on where a lesion is, whether or not they should fix it. If it's on a dominant side, you probably should fix it because it's going to perfuse the whole back of the heart. Right?
Is it better theoretically or easier to treat one versus the other?
I'm not sure if there is outcomes data to show that left dominant people are at more risk than right dominant people, which would be my guess, right? But I don't know if that's true. I doubt it. We probably would have heard about it. The one thing is there's 3 cusps on the aorta, on the aortic root, right? 2 coronary cusps. A right coronary artery comes out of one cusp. The left main comes out of the other cusp. And the other is called the non-coronary cusp. Seems like a waste of space, right? They should put another coronary artery there just to give you a backup. But it didn't happen, Too bad. So this is an example of a left coronary injection. So this is a catheter plug, and you can see the end of the catheter is here. It's engaged with the left main. So the catheter comes up over the top of the aorta, starts at your leg, comes up over the top of the aorta, gets down to the aortic root, it's clicking around in there, and then they rotate it and plug it into a coronary artery, right? Engage the coronary artery. That is not without risk. In about 0.5% of the people, you'll cause a little damage there. Maybe less, maybe 0.1% or something. But it's not without risk. You then inject dye as you're taking these X-ray pictures. And you take a picture 15 times a second, and you look at the caliber of the vessel, as you're injecting that dye. And can anyone see an abnormality in this study? Can you see it well up there? Yeah, it's relatively obvious. So if you're coming down and the caliber is fairly constant and then it changes and it gets narrower suddenly, that's not a good thing, right? And so in this one, if you look at that little takeoff there between this branch, where the LED is branching, that looks a little narrow right there. So the question is, do you go in and fix that? Fixing it means I put a stent in there and open it up such that it has the same caliber as the vessel proximal and distal, or do you just leave it alone? That's the eternal question, right? You can't just leave it alone and put the person on optimal drug therapy, and they probably will live just as long as if you go in and fix it with a stent in this case. However, they may have symptoms, right? So the blood flow might drop, although it looks like this vessel is filling pretty vigorously, right? It's not delayed that much, maybe 1 heartbeat or something. The contrast gets down to the apex, maybe 1 heartbeat late, maybe 2. So flow's okay. So that's the question, do we fix this or not? To answer that, we can use imaging. And the way we would answer that is we would stress this patient and find out if under stress, does this chunk of tissue get perfused less or to a critical level? And a couple of things can happen. Their EKG can change, but that's a pretty non-sensitive marker. You have to be really sick for that to happen. But on nuclear medicine, for example, when we do the stress, we would see a dark region down here over this whole part of the myocardium if the blood flow was lower. Similarly, on perfusion with MR and perfusion with CT, we would see a darker signal down there. The contrast wouldn't get there as quickly, and it wouldn't get there in as large a quantity as in the normal part. The interesting thing in those tests is you have the other part of the heart as a control. So if you see that one part is delayed or lower, you have the normal part of the heart as your control. Right? What happens in nuclear medicine sometimes is you'll have a lesion up here, like in the left main, and so the entire left ventricle is essentially low. And then the nuclear medicine scan looks normal because there isn't a local regional abnormality. It's just the whole thing's low, but it's scaled and comes up, and so you say the person's normal, but they have a left main lesion. Yeah, so that's a problem with that modality. Here's another one where it's a lot more obvious that there's something going on here. That's a very large caliber vessel here. Looks like the circ, and it's coming down to a lesion, which you can see a narrowing here. There's also a slight aneurysmal kind of thing here, like there's a bulge in the vessel there. Just leave that alone. And it turns out you just leave this alone. You don't treat it. Just give them meds and watch, right? Because the stenosis itself is not significant enough to produce any kind of drop in flow across that lesion. So here's a chart of the regions of the coronary arteries that are significant for when you're making a picture and you want to report back that it's normal or abnormal. And so the normal and abnormal lesions are given positions, and the positions are according to this chart, so that the physician whose patient it is can understand where the lesion is, whether or not it's distal or proximal to the aorta. So there's 17 segments of coronary artery, and it turns out there's also 17 labeled segments of the left ventricle in a traditional AHA perfusion map, for example. You break the ventricle up into 17 regions, and we'll take a look at that. Okay, these are the cardiac valves. So remember I said the base of the heart, if you cut a plane through the heart where all the valves are, this is what it looks like in dissection. It's obviously not a flat plane. Here we have the aorta, the aortic valve, the pulmonary valve with the pulmonary artery going towards the lungs. Here are the two coronaries coming off. Here and here, this is the right coronary, left coronary. This is the non-coronary cusp here. The mitral valve is a bicuspid valve, and here's the tricuspid valve going into the right ventricle. I'm sorry, this would be the right coronary artery if this is right ventricle. Often, people have problems with this valve. There's probably 1 million people walking around in the United States that have a mitral valve that is in need of repair, right? And that causes problems in the sense that the blood isn't just going up the aorta, it's going back towards the lungs, and it causes heart failure, etc. So this is a primary problem. Another primary problem is aortic valve stenosis, and we'll take a look at that in some detail. So in cross section, this is how they look. With pulmonary valve here, the aortic valve is behind here. And interestingly, if you look at the left ventricle, the mitral valve is the thing that's sort of centered at the top of the left ventricle, and the aortic valve comes off the side as kind of like an exhaust baffle. The conduction system of the heart is a set of cells called Purkinje cells, and they're myocytes. They're not nerve cells. They're actually heart cells or heart muscle cells, but they're a special type of heart muscle cell that conducts the electrical or excitatory signal sent through the tissue to trigger the contraction. And here at the AV node is where the signal from the right atrium, so this is the sinoatrial node, is a set of cells that is like your own pacemaker. So these cells just fire at a certain baseline rate, right? And they depolarize at a baseline rate. That causes a signal to go across the right atrium. It gets into the ventricle through this AV node right here, goes down through the bundle of His. It's like a cylindrical column of cells going through as the bundle of His of these special types of cells, and it breaks into two branches. One goes to the left side of the heart, and one goes to the right side of the heart. And when you watch the depolarization of the whole heart, it happens quite quickly, and it's because the depolarization of these cells leads that charge, and then the depolarization goes out towards the normal myocytes. And if, for whatever reason, you have an abnormality, say you have an ischemic event, and you kill off the cells here in the bundle of His, and they're in the middle of an infarct, then you're not going to get normal conduction to the rest of the ventricle, right? The ventricle itself will start to have to depolarize on its own rate. Most of the time, you get what's called bradycardia, or the heart slows down, and you need to put a pacemaker in and trigger the heart through a device to keep your heart rate at a reasonable level. And that's sort of bioengineering at its most famous. It's like you've got these people who have a heart that just doesn't work, and you put in this small electronic device in a pocket under their skin and put a wire into their heart, and now they have a normal heartbeat. Right? It's great. So that was done by Earl Bakken in his garage when he was starting Medtronic. So sometimes the more often problem that happens is you'll get a bundle branch block. So a left bundle branch block would be a block here, And so the right side of the heart would depolarize before the left side. And you get this characteristic strange motion of the heart with this bundle branch block. And that can be corrected as well. This is MR derived data in a human left atrium, but it's a human left atrium that's in a jar. And actually the whole heart is in a jar. This is just the image of the left atrium of that heart. And it was imaged for 50 hours on an MR scanner to get super high resolution detail of the left atrial tissue. And inside that tissue, the diffusion coefficient of water was measured, and the sensitivity of the direction of that diffusion was also measured to give a tensor. And then the diffusion, where it is fastest, it turns out where the water is most free to diffuse, the direction that's most free to diffuse is along the direction of myocytes. So you can actually measure with MR diffusion where the myocytes are going, and you can map that as a picture, right? And so this is a picture of myocytes in the human left ventricle, or in a specimen human left ventricle from an MR scanner. So this is kind of like one extreme, doing super high resolution, sort of pathology with MR imaging using diffusion. You can't do this in a person, right? Because 1, 50 hours is too long for them to be in the magnet. 2, the heart's moving, right? So here you can do it because it's stationary and you can just leave it go for the weekend. And so this is the diffusion in the left atrium. This is the diffusion in the left ventricle, showing all of these muscle fibers. And they have this very characteristic sort of helical twisting shape in terms of how the muscle fibers are oriented in the heart. If you guys take cardiac mechanics with Dr. McCullough or something like that, he'll go through this in great detail as to why this organization of the muscle fibers has been achieved. This is MR imaging of ventricular function. And what's happening here is we've got a short axis slice of the heart. And so this is the left ventricle, is the big donut region here. This is the right ventricle, the liver, and this is the chest. This isn't a human, right? Because if you look at this image, you say, well, wait a minute, the chest should have a sternum here and it should be going across, but it's not a human. It's actually a canine. And it also looks like there's a little bit of volume missing because the right ventricle is pretty small, right? So what happens when people, this is how people in Texas, you ever wonder why when you have a heat wave, and they say, oh, 14 people died in this heat wave? You ever wonder what they die of? It's not like they cook, right? So what happens is they get really dry. So they sweat, and what does that mean? Their blood volume goes down. And so when you look, if you were to take an image of their heart would kind of look like this. They'd be ejecting the entire blood volume of their heart, right? And even in the left ventricle, it would squeeze down to almost nothing. And so as their blood volume drops, the way to recover them instantly is you put a line in and give them saline and increase the volume of blood, right? And then everything opens up again. When their blood volume drops, it can sometimes lead to electrical abnormalities in the heart, which leads to death. Anyway, that's an aside. What's shown here is the contraction, the left ventricular. Remember, we were looking at myocardial wall thickening. You can see the wall thickening here. You can see it also shortening. And the great thing about MR is we can put these lines in the heart by saturating the signal in discrete planes before we take the picture, right? So at the EKG, we saturate these discrete planes, and then we image orthogonal to those planes, and it shows up as a Cartesian grid in the picture. And then the delay from when we saturate them to, say, this picture here, the motion basically is tracked by those lines. So it's like fiducial markers in the tissue, and it's called myocardial tagging. And if you look at one of these boxes here, it starts as a square and turns into a diamond. And that strain or that change in shape is characteristic of the muscle function, of the myocardial function. So this is kind of the gold standard of how you measure regional muscle function in the heart. And you can do it in people in an MR scanner, and you can do it in this case in an animal model. It's super high resolution. And here is an interesting case. We start with a Cartesian grid, okay, and then we're going to watch it deform over time. And does that look normal? Remember the last one we saw had this deformation that was essentially uniform over all angles, and they all went towards the center. But here, it doesn't look like that at all, right? It looks like this wall. So this is the right ventricle here. So this is the middle of the septum. This is the lateral wall over here. And what's happening is it's going backwards before it starts contracting. And the reason this is occurring is the right side of the heart has been activated before the left side of the heart. So this is essentially artificially generating a left bundle branch block. So the septum contracts early, it gets thicker. This tissue has not been electrically activated yet. It hasn't depolarized. It's still passive. And so it gets pushed backwards and gets stretched. And then, as the activation comes, it contracts. So this is what a left bundle branch block looks like. We created this artificially by putting a pacing lead here in the right ventricle of this dog and pace the heart using that lead, which is not an easy thing to do in magnetic resonance because you've got all of this crazy RF going on. So you have to have wires and filters and everything that's all magnetic and RF compatible. But that's an abnormal ventricular function with a classic left bundle appearance. And then this is what it looks like from base going down towards the apex. That's the valve plane. You can see each heartbeat, we're moving down one slice. So we're sampling from the base down towards the apex. This is all the hardware that's in there. This is probably where it's being paced from here. So the black signal, those little dots, that's the intersection of the wires, electrical wires that are being used to pace the heart. And so they just show up as black signal. They don't give off an MR signal. Okay, so that was normal cardiac anatomy and pump function, and we got 20 more minutes, and so we're going to start into, that was supposed to be the end of lecture 1, sorry about that, but we're going to start into lecture 2, which looks at abnormal function. So any questions so far on the on what we've done so far? Cardiac anatomy. No, it's all super clear? Okay. Again, I would recommend that those diagrams that I highlighted to say, go memorize the parts of that diagram, I would recommend you do that. And then you have it for the rest of your life. You know what a Wigger's diagram is forever. Okay, so what we're going to do now is we're going to look at how things go wrong in the heart. Again, here's a nice cartoon of the heart with the coronary arteries and the left ventricle and the right ventricle and the aorta, etc. Interestingly, the coronary arteries live inside a fat pad. So there's like in a groove in the heart. So in the groove between the right ventricle and the left ventricle, there's some fat, and the arteries go through that fat. Don't know why, but it's very hard, and it stabilizes the vessel, right? And some people are actually looking at the composition of that fat to determine a person's risk for developing disease. Again, this is just a review of that diagram with all of the valves and chambers, etc. Okay, so here's an example of a CT scan at a particular phase in the heart cycle. And I don't know if you're all oriented yet as to what is normal and what's not normal, but let's go through this. Okay, so this is the aorta, in the middle, this is the patient's chest. We're looking from the patient's feet towards their head. Okay, so this is, on this side is the left side of the patient, and on this side is the right side of the patient. Okay, we're looking up. They're in the scanner, we're looking at their feet up. Okay. This is the spine. Okay, they're lying down. This is their chest. Right. This is the descending aorta. It's coming down towards us. And then this is the root of the aorta that's coming up towards us. Or away from us, actually, I'm sorry. And then we can look and see that's the takeoff here of the right coronary artery, and we can follow that around this coronary artery here, all the way around the back. All right. And then if we come back, let's see if we can find the left. There's the takeoff of the left. It's here, right, as it's coming out. And then we can follow that vessel down to see where it goes. But, oh my goodness, that's some weird stuff, right? Okay, in this view, does this look normal? This is completely abnormal, right? In the sense that this is the right ventricle. Right? This is the septum. This is the left ventricle. It's tiny compared to the right ventricle. They should be roughly equal. You know? This is the right atrium, and this is the left atrium. This is like 8 times larger than the left atrium. So this is a significantly different heart than a normal heart. And you know, one of the things about CT is you don't have to guess at what these relative volumes are, like just from limited views. When you have a completely abnormal heart like this, so you're in unknown territory, right? You can just go through it and absolutely in great detail figure out what's what, and make a 3-dimensional model of this heart. This is obviously some kind of congenital abnormality, and a surgeon, likely fixed this heart at some point and is going to fix it again by the looks of things. So that's CT looking at just basic cardiac anatomy. The thing that kills most people acutely is coronary disease, and coronary disease is just essentially the evolution of these lesions in your coronary arteries. And so it starts out, you look like this when you're about 10 years old. All your coronary arteries, they're absolutely pristine and clean, right? By the time you're in it's now known by the time you're in your early 20s, early 30s, you're starting to develop these little fatty streaks in your arteries, in your aorta, and in your coronary arteries. And a lot of it depends on your lifestyle and diet and things like that, but also on your genetics. And then by the time you get into your 50s and 60s, these fatty streaks have increased in size and sort of become full-fledged lesions that have essentially an immune response, and there's calcium buildup in them, etc. Until finally you get to a level, and it depends at what age. Some people get to this level at 55 or 50 or 45, some people 85, right? Get to the point where this is so thin that any kind of damage or rupture could cause a coagulation event and complete blockage of the vessel. Right? And so that's kind of the history of the coronary disease, and it basically varies from one person to another. Women have the same progression, they're just delayed by about 7 years with respect to men. Men, it seems to evolve at a younger age. And so here, this is another diagram, more detailed diagram of that evolution of these lesions. And the interesting thing is very early on, you get these calcified plaques. And so you get essentially a small rupture and then an immune response, and white blood cells come, and you get fibrous tissue around the damaged tissue, and then you get chondrocytes, like bone cells, go in there and make little plaques. And who knows what that's about, why that happens. I don't think anyone really knows. If the plaques are constructed really well, it's like your own stent in a way. It doesn't mean it's not a bad thing actually to have the calcium there in the sense that it probably stabilizes that plaque. It is a bad thing to recognize that you have calcium in your vessels because it says you're growing lesions, right? Some people don't. You image them at 55 and they have no plaques and they have no calcium in their vessels. They're very lucky. At 55, that's about 40% of the people, maybe 30. But the rest of us have plaques. Where you don't want to wind up is here, where you have this massive thrombus developing in the vessel and it completely shuts the vessel off. Yeah?
So at what point in this would you do something if you saw it versus wait and see how it develops?
That's a fantastic question. So I'm going to repeat it for the recording. And the question is, at what point do you intervene and try and change the course of events if you can? And right now, the intervention or the guidelines and the way medicine is practiced is you intervene right about here when the person shows up at the ER and they have chest pain. So when you develop symptoms, that's when people start talking about intervening. If you're asymptomatic, there is absolutely no recommendation in the American healthcare system to screen for heart disease, which is kind of interesting, And in fact, there's a recommendation that you shouldn't screen for heart disease, because what you will do is you'll find heart disease and you'll overtreat it, right? So in this healthcare system, you wait until somebody develops symptoms or has a heart attack, and then you treat them. In my mind, that's kind of like if I have a playground out at Del Mar and it's by the cliffs and kids keep falling off the cliff, say, well, what are we going to do about this? It's like, well, we'll buy ambulances and put them at the bottom of the cliff, right? And then we'll take care of them when they hit the bottom. You wait till they fall off. So it's up to, in a way, your generation in this country is going to figure out, do we stick with this pathway, of waiting till people develop symptoms or wind up in the hospital before you treat them. In other healthcare systems, that they're sort of making more proactive, like early detection calls. One thing you can do is move this whole event back to this event, because this happens early. This happens when some people in your 30s, 40s, 50s. And, what do? You're not going to intervene in the sense that you put a stent in there, but you can go on a drug, which is called a statin. And statins take your LDL from, say, 100 down to 80 or 60. And it turns out that your risk of having a heart attack is absolutely proportional to your lifelong exposure to LDL, the cholesterol. Right? So if you drop that exposure such that the integral goes much slower, you're just going to push farther back before you're at major risk of having a heart attack. So that would be my plan, personally. As a person who can find out this information, that's what I did, and that's where I am. So looking for disease, so if somebody doesn't feel well and they're starting to sweat and things like that, and they might have a little pain, in women it's harder. They have different types of symptoms, and they push through pain better. But if you're trying to confirm that the person does have coronary heart disease, there's a number of tests you can do, and these are what they are. And the sensitivity and specificity is over here. Who knows the definition of sensitivity and specificity? Okay, so we'll have to go over that. Sensitivity is like, if you are positive, what is the probability that the result will be positive, right? And so how many positive people do you capture? I can have very high sensitivity by calling everybody positive. I will capture everybody. But then I have low specificity in the fact that I also included a lot of normals with my positive call. So you usually ramp back and you say, okay, where do I make the positive call using some test? So an exercise echocardiogram, everybody gets this in this country, and it's a terrible test, right? it basically has very low sensitivity. You can get by this test and have coronary disease, which many of my friends, not many, 3, were able to do, right? They had severe coronary disease, and yet their EKG was perfectly normal. And they were able to get to a very high exercise rate and keep it normal because they exercised a lot. So they compensated somehow, right? It has pretty high specificity, right? So it doesn't put normal people in the abnormal box very often. Right? Exercise echo, you take an echocardiography while the person is on a bike, and you see how their heart responds to the exercise, just the dynamics of the heart. SPECT we'll look at is this nuclear imaging. Remember, you're glowing, whether or not there's perfusion. These numbers, this is a lie. This is close to the truth. We'll see that in actual studies in the real world, you never hit 92% sensitivity with this. That's just fiction, right? This number. Dobutamine echo means you give the person a drug called dobutamine. It's like adrenaline, and you don't have to exercise, but your heart starts beating really fast, right? So it's just like adrenaline, really. It's like, oh man, something big happened, and your heart starts going. And then that's how you drive the heart to a higher rate, and you look at it with echo, and if it continues to beat normally, it's likely the person doesn't have coronary disease. If the heart starts to beat abnormally, showing that there's a perfusion deficit, then that's positive. And again, these are generous, these numbers here. Okay. You can do the same thing with MR. This is perfusion testing, where you, instead of giving them dobutamine, which is like adrenaline, you give them a drug like adenosine, which basically dilates all your distal vessels. And so the blood flow demand goes up, and you see if the heart can respond to that by measuring the blood flow with an imaging technique. You can do it with echo, SPECT, or MRI. You can also do it with CT, but it's not commonly done with CT. And so that's perfusion stress testing. So there's a whole, this is a Chinese menu of great things you can do, right? And then there's CCTA, which is just inject contrast and look at the vessels. Just take a look at them, see if they're stenotic, right? That has super high sensitivity, right? So you get all the people that are abnormal, but you also include people who are not normal, but you wouldn't intervene. You wouldn't put a stent in that lesion. So they wind up going to the cath lab, they inject, and they go, well, that's not serious enough to treat. But the CCTA said there's a lesion here. And there is a lesion there, it's just not serious enough, right? So this is the thing that has to be improved with CT through engineering and development and stuff like that, is that sensitivity, or specificity, sorry. Sensitivity is pretty good. The other thing about CCTA is if you have chest pain, you wind up in the ER and you go get a CT, and the CT is normal. So they look through and all the vessels are open, right? If they make that read, over 99% of the time, you are normal. So it has a huge negative predictive value, that's called. And what that means is you can go home, right? You're in the ER, you got chest pain, they just give you Rolaids and you go home, right? Because you don't have coronary disease. And so it's the National Health Service in Britain. Now when it's their standard of care, when somebody shows up at an ER and they have chest pain and it looks like they're having a heart attack, they don't keep them overnight, work them up, do an EKG, do this, do that. They don't do any of that. They just take them to a CT scan. And they CT them, 75% of those people then go home that night, right? Because they're not having a heart attack, right? In this country, that is not what is done, right, at all.